Going. I just thank you. So we'll start skipping him to Michelle Tedder from the Black Women's Health Imperative. And just for all public commenters, please note there is a clock that is on the screen. We have a pretty strict ending to this clock, so I'll have to cut people off after the time. We're looking forward to your comments. Welcome, Michelle.
Good morning. Thank you. Before I get started, I just wanted to make a note that the Black Women's Health Imperative has received support from Novo Nordisk to launch a campaign called Reclaim Your Wellness in collaboration with healthywomen.org to elevate the stories and lived experiences of women impacted by obesity. Well, good morning, everyone. My name is Michelle Tedder, and I'm a Senior Program Manager for the Black Women's Health Imperative, and I'm particularly excited to speak with you today, given my own continuing and successful fight to manage obesity. As a Black woman, I know all too well that I've been unusually fortunate to have had access to bariatric surgery several years ago when the medications ICER is reviewing were unavailable, and to be able to maintain my health gains with those medications now. I want to start by reiterating what we at BWHI have communicated to ICER over the past several years. The structures across healthcare, housing, education, employment, clinical trial participation, and access to healthy foods that drive inequities were created through centuries of intention. Black women and other people of color will continue to have shorter, harder, and sicker lives unless we prioritize access to the full range of interventions available to reverse the disproportionate burden that big ticket conditions like obesity exact on our communities. The inequities associated with obesity are significant. ICER noted the disproportionate prevalence of obesity in communities of color. Black women are 2 to 3 times more likely to have obesity or be overweight than their white counterparts. Obesity may be recognized as a chronic disease, but our health system approaches it with a sense of judgment that centers treatment on personal responsibility, not evidence-based interventions. Given that weight stigma and systemic racism continue to impact the care we receive, it is not surprising that obesity is the most undertreated chronic disease in the US. Just 2% of US adults eligible for obesity medications receive a prescription. If the existing trends in obesity continue, it is projected that 52.5% of Latinas and 49% of Black women will develop diabetes in their lifetime, compared with 31% of white women. We had asked that ICER consider the potential that new treatments for obesity have a value in communities of color that is quantitatively and qualitatively different from that in white suburban populations. Black patients are less likely to be offered behavioral interventions for obesity. Studies have demonstrated that Black patients participating in lifestyle-based obesity interventions lose approximately half the weight of their white counterparts. People of color also have difficulties accessing bariatric surgery and poor surgical outcomes. Black patients have higher odds of readmission and multiple grades of complications, including death, compared with white patients. Hispanic patients have higher odds of a grade 3 complication compared with white patients. ICER's evidence report cites to evidence that safety and efficacy of obesity medications is not mitigated by race. Semaglutide appeared to result in greater weight loss for women. We cannot emphasize the urgent need for access to the full range of obesity medications enough. Anti-obesity medications are non-covered by many payers, even if they are part of a STEP protocol toward coverage for bariatric surgery. This is the reality that most Black women face, a high likelihood of developing obesity combined with lack of access to treatment options that level the playing field in terms of safety and efficacy. I was lucky that my physician believed that I was unable to manage obesity despite exercising and maintaining a healthy diet and recommended bariatric surgery. It was life-changing for me. I continue to exercise and eat a healthy diet, but would not be able to maintain my weight loss without semaglutide. I would also like to address portions of ICER's evidence report that BWHI believes may have reduced the calculated value of the new treatments reviewed. ICER did not account for non-ischemic heart failure in its review. Our comments included evidence on the link between non-ischemic heart failure and obesity. In addition, Black patients are 40% more likely to have high blood pressure and far less likely to have their hypertension under control. We are concerned that ICER's assumptions unintentionally relied on the lived experience of a white male population. We had recommended that ICER's model reflect the standard of care in anti-obesity medication continuation. The evidence report was unclear on whether non-responders exited the model at 3 or 6 months or remained on treatment throughout the model time horizon. Over half of women of childbearing age have at least one cardiovascular risk factor, and cardiologists recommend that women address obesity before becoming pregnant. Access to anti-obesity medicines is of tremendous importance for young Black women, given that our maternal morbidity and mortality rates are more consistent with those of developing countries than that of white women in the US. BWHI requested that ICER's model take chronic kidney disease into account. Chronic kidney disease is not always associated with type 2 diabetes, and Black patients are 4 times more likely to have chronic kidney disease than white individuals. Obesity treatments that are metabolized in the kidneys would have limited benefit in individuals with chronic kidney disease and obesity, and we expect that the medications would not be cost effective. Semaglutide and liraglutide are metabolized in the liver. Finally, BWHI appreciates the opportunity to express our concerns, and I ask that the voting panel carefully consider the points we have raised in its deliberations. A written summary of this discussion was submitted in advance of the meeting for your reference. I welcome any questions that you might have. Thank you.
Ms. Tedder, I just wanted to say thank you so much for joining us. It's really so helpful. Thank you for bringing the patient perspective, and thank you for pointing out these critically important issues around bias and issues that affect women more than men and Black women more than other groups as well. So this has been critically helpful and critically important. Are there any questions from the voting panel? Okay, thank you again for your very thoughtful comments, and thank you for joining us. Let's transition. I do believe that Dr. Jason Brett has been able to log in. Is that correct?
Yes, I am here. Can you hear and see me?
Yes, we can. Thank you for joining. So yeah, I would just ask you to introduce yourself, declare any potential conflict of interest, and just remind the 5-minute clock. I will be strict with enforcing it.
Sure.
Looking forward to your comments.
So good afternoon, everyone. I'm Dr. Jason Brett, Executive Director with the Medical Affairs team at Novo Nordisk. I am a physician committed to advancing patient care with a focus on cardiometabolic diseases, including obesity. I would like to begin by stating that Novo Nordisk, together with its partners, has been fully committed to helping improve the lives of people with obesity by changing how the world views, prevents, and treats obesity. Obesity has long been misunderstood, trivialized, and stigmatized as a lifestyle issue. We remain steadfast in our long-term commitment to drive change across the obesity community by creating scientific innovations through patient-centered research. Our commitment is demonstrated by a robust clinical development program called STEP for semaglutide 2.4 milligrams, which enrolled approximately 5,300 subjects, showing sustained and clinically meaningful weight loss when compared with placebo. Furthermore, we are currently conducting a cardiovascular outcomes trial of approximately 17,500 patients called SELECT to evaluate semaglutide 2.4 milligrams for superiority as compared to placebo, both added to standard of care in reducing the incidence of major adverse cardiovascular events for people with overweight or obesity and established cardiovascular disease in the absence of diabetes. Broadening our understanding of this multifaceted disease is much warranted, particularly as obesity affects 4 out of 10 persons living in the United States and is associated with more than 200 obesity-related complications. We strongly support efforts that advance the understanding of obesity as a serious, chronic, and progressive disease. However, we would like to state our position of exercising caution in interpreting this model developed by the ICER team, which is an oversimplification of a very serious and complex disease, and which has failed to capture many important aspects of obesity. Most notably, the assumptions and estimates in the model do not adequately address the real-world complexities of obesity and consequently underestimate the health and societal benefits of anti-obesity medications. First, the base case economic analysis included only diabetes and cardiovascular disease and missed many important comorbidities, including but not limited to obstructive sleep apnea, osteoarthritis, and certain cancers, despite strong clinical evidence that obesity potentiates these diseases. Not just the base case, but these comorbidity effects were also excluded from the model's sensitivity analyses. In contrast, peer-reviewed investigations have shown that including the full impact of these additional obesity-related comorbidities on dimensions of cost, quality of life, and mortality substantially impacts overall clinical benefit and cost effectiveness estimates. Failure to include these important elements leads ICER to an incorrect conclusion. Second, ICER only considered the impact of weight loss on mortality through reductions in fatal cardiovascular events. This is inconsistent with high-quality evidence demonstrating the substantial increased risk of all-cause mortality associated with obesity and the benefits of weight loss in reducing all-cause mortality. This evidence includes meta-analyses that synthesize 239 and 34 studies respectively. Excluding this large body of literature from the evaluation, even as a sensitivity analysis, introduces a bias that underestimates the health benefits of weight loss. Of note, these criticisms are mutually shared by other individuals and organizations who submitted separate public comments in response to ICER's evidence report. The consensus was that ICER's model was overly simplistic and does not reflect real-world complexities of obesity as a serious and chronic disease. The consequence of these shortcomings is that the conclusions drawn by ICER on cost effectiveness are not accurate. In conclusion, Novo Nordisk strongly encourages using caution when interpreting these findings without thoroughly considering the model's limitations. We are today in a unique position to ensure that suitable care and treatment pathways can be put in place, thereby allowing people living with obesity the opportunity to achieve sustained and clinically meaningful weight loss that can positively impact their overall health and well-being. It is our sincere hope that the consistent work of several partners with a common purpose is not set back, and we respectfully and strongly request that ICER address these concerns in the final evidence report. Thank you.
Thank you for joining and thank you for your comments. I guess especially given the nature of your comments, I want to make sure to give the ICER team a chance to respond. But before I do that, could I just ask one question of you? It's so good to have you here and have your comments, but my understanding is you declined participation in the policy roundtable. If that's correct, can you comment on why you're declining participation in the policy roundtable? It's a very helpful forum that it has payers and manufacturers and patients. It's a really helpful, so maybe if you could just comment if that's right, why you're declining to participate.
Yeah, I would just say it was really an internal business discussion by others, and including other partners at Novo Nordisk. But obviously, we do thank you for this opportunity to at least give us an opportunity to make public comment. So thank you for that.
Oh, sure. And then could I just maybe a bit from the ICER research team responding to the criticism of the model?
Jason, I'll speak on behalf of ICER. For everybody, my name is Francesca Bodwin. I'm a senior medical advisor with ICER. Dr. Brett, thank you for your comments and also for Novo's collaboration during the developmental phases of the report. I would like to highlight that we, in this model, conferred benefit to the interventions that has not been proven in the clinical trials. Most of the outcomes, we're really looking at 1 year weight loss outcomes that then we extrapolated to have a cardiovascular benefit that has not yet been proven, as you highlighted. This is work in progress, and we're eager to see the results of those studies. And so thank you for that subsequent work. We do acknowledge there are considerable uncertainties around these interventions, and we do highlight that in the report. And that is where this, the future of this needs to go. We acknowledge that the interventions in semaglutide in particular are clinically effective, and we are pushing back on the at current pricing, they are not cost effective. And I'd like to, if I could, tap on Dan from our economic team to talk a little bit about some of the other things that you mentioned, obstructive sleep apnea and osteoarthritis, and where we attempted to capture some of those other benefits in the model, and then the addressing of other obesity related conditions.
Yes, thank you, Francesca, and I will comment on that. We did include a disutility associated with each BMI unit or a gain in utility for each reduction in BMI. And that was from clinical trials. And so that disutility or removal of the disutility as patients lost weight reflects many of the components that were mentioned in this comment. Things like sleep apnea. The immediate benefits of weight loss on sleep apnea were captured in the model as part of this utility gain that patients got for reductions in BMI. We were concerned about double counting in a lot of cases because we're using relatively generic risk equations that already attribute some benefit to having lower weight on mortality and on cardiovascular risk. So the other aspects of sleep apnea, the impact of sleep apnea on cardiovascular risk should have already been captured in the AHA-ACC risk equation models. So to add another benefit that is cardiovascular or mortality benefit to reductions in sleep apnea would have likely been double counting many of these. When it came to cancer, there is a paucity of evidence around what a 10% reduction in weight or a 12% or 13% reduction in weight, what impact that has on cancer risk. We do know that there is an impact of weight, an association of weight and cancer risk. We do not know what impact therapies would have on that. We did do a sensitivity analysis, but it was not included in our base case. And the reason for that was because we just felt there was not enough evidence at this time. And then regarding CKD, we did capture the costs and impact of weight loss on CKD as it relates to diabetes. It was part of our diabetes, part of the model, the health state of diabetes. We did not capture CKD where it does not occur as a result of diabetes. And that is a limitation of the model. But there again, we have no evidence, no information on what impact modest weight loss has on risk of CKD in the long term. So that was the reason that we did not include that again in the base case.
Thanks so much, Dan. Steve Kogut, we are a little over time. Can we defer? Yeah, thank you so much for understanding. Appreciate it. So let's move with that to our final public commenter. We are a few minutes into lunch and we'll try to get things moving as fast as we can. It's Theodore Ted Kyle, founder of Consciental.
Thank you very much, and I appreciate the opportunity to join this comment period. And I want to start by saying that ICER deserves credit for developing a complex and remarkably transparent model. And can you hear me okay?
Ted, you're a little in and out. We can sort of hear you. And then can I also remind you to state, I know we see it on the screen, but to state your conflicts of interest?
Sure. I receive honoraria from Nutrisystem and Gelatin. And I don't see it listed here, but I have spoken on programs that were funded by Novo Nordisk and received honoraria for that.
Thank you.
Okay. ICER deserves credit for developing a complex and remarkably transparent model of the effectiveness and value of obesity medicine. However, I would like to caution that it two important factors about obesity and its treatment. First is the human dimension of obesity. And second is the inescapable fact that one size does not fit all when we speak about treating obesity. Regarding the human dimension of obesity, ICER deserves credit for reaching out to advocates for people and communities living with this complex and chronic disease. However, this model does not fully capture the human dimension of obesity and the profound effects of untreated obesity upon the lives of people who have it. In fact, it seems that it primarily emphasizes cardiovascular events. Anyone who is living with obesity will tell you that cardiovascular events are distant threats that do not match the daily effects of obesity on their lives. In reading the subjective narrative of the evidence report, it is not clear that its authors really understand this dimension because it is not fully reflected in the report. The other major factor to consider is that obesity care is something where one size does not fit all. This is because of the heterogeneity of the disease, which Dr. Kaplan mentioned earlier, and the great diversity of needs in people living with it. In contrast to that reality, this report is written in such a way that summaries of it suggest the report, and I'm quoting, affirms Qsymia as the most cost-effective obesity treatment. Here I am quoting the associate editor of Endpoints News, but his words are typical of most reports on this effort by ICER. I agree strongly with the Black women's health imperative that this report should do much more to account for the undertreatment of obesity, its health impact, and the diverse needs of people and communities living with obesity. As written, many health plans and providers will use this report as an excuse for limiting the options of these people. This will be a tragic mistake. Thank you very much.
Thank you for joining. Thank you for your comments. Does anyone from the ICER staff want to respond?
Thank you, Mr. Kyle. Appreciate your comments. I will say in general, ICER is very committed to promoting health equity and beyond that, reducing and eliminating health inequities through our work. And we've attempted to, as you highlighted, model something that is very complex, but there are areas where there are uncertainty. And we in our narrative do attempt to highlight that in the report. And for instance, we assume that hypertension is equally treated among the arms. And so what we don't address is how do these drugs work in patients who have untreated hypertension, and what is the impact there. And I think that gets back to the original comments again that we heard from the first patient representative. And so this is challenging. We acknowledge it's challenging, and your feedback and other patient advocacy groups are so important to this process. And so as we view our final report, we will try and emphasize some of the things that you are highlighting here today. But thank you very much for your comments.
Thank you.
I think since Mr. Kyle saved 2 minutes of his time, I will actually go back to Dr. Steve Kogan. I think he had a question for Dr. Brett, and then we'll close for lunch.
Oh, terrific. Thank you. Well, first, thanks, Dr. Brett, for being available today for questions. Just wondering, you had mentioned some other outcomes that would be important to capture in the model, and be curious to know if Novo has done its own modeling incorporating these outcomes, maybe for other nations' regulatory authorities, and did the results of that modeling perhaps inform the company's pricing on semaglutide?
I'm not sure Dr. Brett is still on because we shift from person to person. They have done their own modeling. And as mentioned, they focus pretty heavily on the 2-year model, which, as you heard from Dan Touchette, has some concerns that when it's preventing events, it's as if they will never happen in the future if you stop taking the drug. And so while they've modeled a bunch of outcomes, a lot of what's going on there is that when you take the drug for a short time and you use equations that say an event never is going to happen, you may overestimate the value of a therapy.
Got it. Thank you.
No, that's very helpful. I think I apologize. We're 12 minutes over into lunch. Maybe I'll just give it to Steve Pearson for a moment to see what you want to do with. Do you want to resume it at 12:45 or?
Yeah, I think we need to stick with our timeline. So let's come back at 12:45. Apologies if that means that lunch is a little bit shorter, but everybody can scoot off to lunch and we will reconvene right at 12:45 Eastern. Thank you, guys.
Thank you, everyone.